My name is David Morris, and on behalf of the UAB Department of Physical Therapy, I'd like to welcome you to the first endowed Marilyn Gossman Lecture for the Advancement of Physical Therapy. First on our agenda tonight is acknowledgement of a few special guests with us tonight. First of all, we are pleased to have members of Marilyn's family with us, and they've traveled quite a long way to be here with us tonight. So would you please stand and let us thank you for joining us, the Gossman family. As you likely know by now, we are celebrating 50 years of physical therapy education here at UAB this weekend. And we are pleased to have with us tonight the first PT to be hired at UAB, Dr. Joan Bergman. And she is also responsible for initiating the educational program at UAB back in 1964. So, Dr. Bergman, would you please stand and let us recognize you for starting this program that's meant so much to all of us. Accomplished individuals like Marilyn Gossman are unlikely to achieve the great success that they do without great mentors. We're pleased to have with us tonight Dr. Geneva Johnson, the former chair of the Case Western Reserve Masters of Physical Therapy program and therefore one of Marilyn's most valued mentors. Dr. Johnson, please stand and let us recognize you. We are also pleased to have many current and former faculty members of the UAB Department of Physical Therapy here with us tonight. So please, any former or current faculty members, please stand and be recognized. It's half the crowd. In order to endow an annual lectureship, we were charged to raise $100,000, which is no small task. Many individuals were responsible for helping us meet that goal, and we would now like to recognize all those individuals who contributed to this important effort. The names of the donors are listed in your program, and please join me in thanking these individuals for their contributions. And although the lectureship was endowed this past April, funds from the account will not be available until later this year. And even though we could not access the funds yet, we thought it was very important to do this in the 50th anniversary year of our program. We were able to do so with a generous donation from Therapy South. So please join me in thanking Therapy South for sponsoring tonight's event. Finally, I'd like to recognize the School of Health Professions External Relations Office, Katie Adams, Amanda Sherman, Melody Stewart, Kevin Storr, and Julie Borden for successfully executing the Gossman campaign and for organizing tonight's activities. So join me in thanking them as well. Now I'd like to welcome Dr. Harold Jones, the Dean of the UAB School of Health Professions, to the stage to present the official endowment of the Marilyn Gossman Lectureship for the Advancement of Physical Therapy.
Can you hear this? Okay, I just want to make sure it's working. Before I get started, I feel like we've thanked everybody else except Dave. So David has provided incredible leadership in the department over the years, and I want to recognize David for all that he does for the department and the profession. You know, on behalf of the School of Health Professions, I want to welcome you to this inaugural lecture in the Endowed Marilyn Gossman Lectureship Series. We're really excited about this because we know that it will be an important series that will continue to add and contribute to advance the field of physical therapy. I especially want to welcome, as did David, Dr. Gossman's family, her friends, her colleagues, and all of those of you who have helped make this lectureship possible tonight. You know, I never had the opportunity myself to meet Dr. Gossman, and I'm going to call her Marilyn from this point forward because everybody else does. So I want to do that. But even though I didn't meet her personally, I at least know three things about her that are important. First, Marilyn was and is a legendary figure in the physical therapy profession. She was a visionary, she was an innovator, she was passionate about her discipline, about physical therapy, about advancement of the profession, and committed in an incredible way to her students, not only while they were here, but as they moved through their careers. She was part of a wave of outstanding PT leaders that were educated at Case Western Reserve, as has been mentioned. Coming from a family that I'm married to an Italian-American wife, I would tend to call them the Case Western Reserve Mafia, but they came to UAB and they had an incredible influence on our program over many, many years and continue to do so. She came here in 1967 and she led in many different ways the program for the next 30 years. She had many state, national leadership roles related to APTA, and she helped push the discipline forward, especially in the area of education and innovation in that. Secondly, in addition to being a legendary figure in the profession, I know she had a profound impact on virtually thousands of individuals. She actually touched more than 1,500 students simply during her time at UAB, and mentored many of them well past their education here and deep into their careers. And she provided mentoring to others throughout the profession who didn't go to school at UAB, but still cared so much about profession and the development of those leaders that she was there and a steady force in bringing forward leadership throughout this country. You know, graduates seldom can get into a conversation with me who were here before 2000 without having, within 5 minutes, starting to talk to me about Marilyn. And I think that's an incredible testament that students that many years down the road, that is what they think of when they think about their educational experience here. Thirdly, Marilyn's influence is still felt every day in the physical therapy department here at UAB and in our school. The department continues today to build on the foundations of excellence and innovation that Marilyn helped construct, and to follow through on her vision for physical therapists to indeed be leaders in the healthcare arena. And that UAB should champion that cause and develop those leaders who will make the difference in healthcare. What I would like to do at this point in time is for you to take just a moment with me to look at a video that was prepared that talked a little bit about Marilyn and talked a little bit about the relationship of Marilyn to this particular endowment.
Marilyn Gossman was a physical therapist, educator, researcher, and influential leader. She served as chair of the UAB Physical Therapy Department for more than 30 years. Along with Joe Clellan and Kara Adams, she grew the program into one ranked among the 20 best in the country. Marilyn was known for leadership, vision, and innovation. UAB was among the first to establish an assistance program, a post-professional master's degree, and an entry-level master's degree in physical therapy.
Well, Marilyn was a visionary, and she was always thinking of the future. And she had a real gift for seeing possibilities when other people didn't.
In 1998, Marilyn died of breast cancer, but her legacy lives on today through the hundreds of students and faculty members whose lives she touched. And it is her UAB family that is continuing her legacy of excellence and innovation by establishing the Marilyn R. Gossman Endowed Lectureship.
A lot of our current students don't really know who she is or what she did. So by doing this type of an effort, we are going to make sure that everyone knows the contributions that she made and the mark that she made on the profession, not only in Alabama, but throughout the U.S.
Your generosity proves that if you give something, you can change everything. Thanks to you, the PT department raised more than $100,000 and endowed the Gossman Lectureship. Guided by Marilynn's legacy of giving back and due to your generosity, UAB will host a renowned therapist every year to give a free, open-to-the-public lecture. In line with Marilynn's forward vision and UAB's aspirations, the Gossman Lectureship will forever share knowledge that will change your world.
This lectureship was officially established with a resolution that was passed by the University of Alabama System Board of Trustees. It details many of the accomplishments that Dr. Gossman was responsible for. And frankly, it's too long to read and it has too many whereases and therefores. However, there's a copy of it down front. I would encourage those of you who would like to, once we are through with the lecture this evening, to come down and take a look at the resolution and to kind of see some of the details that are in it. This particular resolution that you'll be looking at, once we finish tonight, it will go and it will be hung in the Department of Physical Therapy in a permanent and very visible location, so that students for many years to come and people for years to come that come through the facility will understand the many contributions that Marilynn made to the profession and to our program. However, at this time, what I would really like to do is to present a copy of this resolution to Marilynn's family, and if they would mind joining me on the stage here, I want to share that with them. Kevin, you want to help me? Thank you. On behalf of the Board of Trustees, and really a very grateful department and university, in recognition of all the incredible things that Marilynn contributed to us, to the profession, and so many people's lives, and the difference that she made. It's my pleasure to give a copy of this to the family, and so here's your copy, and congratulations, and thank you for all that you did to support her through all those years. It's now my pleasure to introduce the interim chair of the Department of Physical Therapy, Dr. Diane Clark. Diane will be introducing our speaker today at this inaugural lectureship. Diane?
Thank you, Dr. Jones. Can everyone hear me? Excellent. It is my great pleasure to introduce tonight's speaker, Dr. Anthony Delitto. Dr. Delitto is a professor in the Department of Physical Therapy, Associate Dean for Research, School of Health and Rehabilitation Sciences, and Vice President of Education and Research, Centers for Rehabilitation Services at the University of Pittsburgh. He earned a Bachelor of Science in Physical Therapy from the State Universities of New York, Buffalo in 1979, a Master's in Health Science in Physical Therapy from Washington University in 1980, and a Ph.D. in Social Psychology from Washington University in 1990. His research history has been highly successful, exploring a wide range of topics, including diagnosis and management of low back pain, other musculoskeletal interventions, and health services and implementation research. He has authored well over 100 manuscripts in peer-reviewed journals. He has served on many key panels and committees, including the National Institutes of Health Task Force on Low Back Pain and Blue Ribbon Panel, as well as on the APTA's Models of PT Service Delivery Task Force. He has received numerous prestigious honors and awards, many from the APTA, including the 1992 Golden Pen Award, the 1997 Marion Williams Award for Research in Physical Therapy. He has received the Orthopedic Section Steve Rose Award on 5 occasions, the 2003 John P. Malley Lecture Award, and the 2007 Lucy Blair Service Award. He was named a Catherine Worthingham Fellow of the APTA in 2000 and delivered the 2007 Mary McMillan Lecture, the highest honor bestowed upon any U.S. physical therapist. I could go on, but instead it is my honor to present to you Dr. Anthony Delitto, the first Marilyn R. Gossman Lecturer for the Advancement of Physical Therapy.
Well, thank you for that very kind introduction. And I want to first express my appreciation and for the University of Alabama at Birmingham, actually, for them creating this lectureship for a most deserving individual. And secondly, I want to tell you how honored I am to be this inaugural lecturer. You notice I put this on my slide, the inaugural lecture. This is an unbelievable honor for me. And I think I knew her as Miss G. And I captured these 2 pictures. My wife and I actually have this picture hanging in our house of her. And to me, this captured Marilyn. At the helm, you know. When I was preparing this lecture, I had a number of stories I wanted to tell, but the worst thing you can do in a lectureship like this is get emotional right at the start. So I promise I'll revisit Marilyn at the end of this lecture, because otherwise I'm not going to be able to do it. So with Marilyn over my shoulder here, the thought is to come here and be provoking. And I titled this The Opportunities in the Perfect Storm. And I want you to envision the perfect storm. Some of you, when you think the perfect storm, I hope you're thinking of George Clooney. And at the end of that movie, when this giant wave is coming crashing upon him, you have to ask yourself, what in the world is the opportunity here? Okay, and I think it was Einstein who said, in times of difficulty lie opportunity. And I tried to pick up on that with this notion of the perfect storm, because I really think that this definition of the perfect storm, where it's the confluence of events that drastically aggravate a situation, is exactly what's happening to us in healthcare right now. And I believe, in spite of this perfect storm, there's a phenomenal opportunity for us as a profession. And I'm going to try to point this out in my lectureship to you. And really what I'm going to point on is this idea that we've tried to profess for a while. It's not a new idea. The idea of implementing evidence-based practice standards, and which needs, for it to be successful, there needs to be an implementation of these standards. And we know that for the past 15 years that this has been a very stubborn goal. It's very difficult to get implementation across in our field right now. But I think the opportunity is there in this area of payment. And I talked to the students today about this. I think it's not a secret. I believe it's not in a very short period of time we're going to be moving from a payment system that's a fee-for-service system to something that really emphasizes quality. And what better way to address quality than to start looking at evidence and start implementing evidence in our practice. So it is this perfect storm, and I believe it's not something we should embrace. I'm not here to teach you evidence-based practice 101. We know these steps to evidence-based practice. We've professed them for a long period of time. Begin with the patient, ask the answerable question, find the best evidence, assess the evidence. We have this nice hierarchy over here. At one time, this was news to people. It's not news anymore. We've all seen this. We all know this. But what we have perhaps forgotten about, I think, and I'm going to make the case that we need to now redirect our attention to, are these last two components of evidence-based practice. We have to actually do it in the clinic. We have to integrate results with the patient's unique biology expectations, and we have to find out if it's working. Are we any better off doing this? We have to evaluate our performance. Part of evaluating our performance is to ask ourselves, are we actually doing this with our patients? Are we doing it with the patients that we see every day? Are we practicing with best care standards every day, comprehensively with all the patients that we're seeing? That's the first part of it. Then the second part of it is it doing any good? Are we any better off doing this than before we did this? Okay? And it's a really important question, and it's a very important self-reflection. So I'm going to talk to you about what I know about for a little while, low back pain. And I want to start by saying when we don't have data, and when we don't operate from the standpoint of evidence, or we don't have clinical data available to us, in lieu of this data, we are commonly misled by myths. Have you heard this one? 90% of people with back pain spontaneously recover. Heard that? Well, it's a myth. It doesn't happen. When you finally look at data, this doesn't happen, yet this myth persists. And I'm going to now go through this is my only epidemiological slide that I'm going to show to you, I promise, because I don't like talking about epidemiology, it bores me. But what I'm going to try to take the perspective of with this slide is to show you where there's opportunity. Right away, I'm going to talk about opportunity. This is Martin. This is an investigator from the Rick Deo group. And for those of you who follow people, Rick Deo is a family medicine physician who publishes a lot in the area of low back pain. And what he did was a really simple study. He looked at Medicare data, and he compared adults with spine problems to adults without spine problems. And he did that in 1997 all the way up to 2005. And when you compare the two, there's this differential in money that's being spent. And when you look at that differential, it amounts to about $2,580, which doesn't sound like a lot of money until you multiply it by the 33 million people that have spine problems. And you get this number of $85.9 billion. And then, to top it off, to even make it more profound to you, only heart disease and stroke were substantially higher. Now, if I told you that we spent the most amount of money on heart disease, wouldn't surprise most of you people. We've learned from a long time heart disease is the biggest killer, right? And if I told you stroke, that we spent a lot of this, it still wouldn't surprise you. But then if I told you backache was the third thing, would you think there's some low-hanging fruit here? I mean, should we be spending this amount of money on backache? I mean, is it really worth it? And if we look at this even closer, we first have to ask ourselves, do these people really spontaneously recover? If they spontaneously recovered, why are we spending all this money, right? And the answer to that question is pretty revealing. If you listen to what I had to listen to over the years, most people with back pain get better no matter what you do. You look at people who actually study it, and here's a study out of the British Medical Journal, 490 people. It's a good study, good journal, right? All these people, almost 500 people, consult a general practitioner with back problems. 92% of them discontinue seeing this patient, their PCPs, their general practitioners. Thus, most people get better, right? But when 1 year later they asked these people, only 25% said they fully recovered from their back trouble. So they just didn't go back to their primary care physicians. They went somewhere else, okay? And just so you realize I'm fair and I'm not throwing stones just at the physicians, okay? There was a study that was published in Spine in 1998 that looked at a good number of people that either received physical therapy or chiropractic treatment. And only 18% of these people reported no recurrences over a 1 year period. And 58% sought additional health care. Only a third of them went back to the original practitioner. So my point here is even in PT and chiropractic, we can't be fooled with the fact that just because they don't come back, they're better. All right? And I think we totally overestimate spontaneous recovery for back pain. We totally overestimate it. And we look at our claims data in our integrated payer within UPMC, and I can tell you clearly it's there. Within a very, very short period of time of our patients seeing one practitioner, they're starting another episode of care with a different practitioner. Okay? Now, you might say we need to, educate people on guidelines. Well, for 20 years, we've been publishing guidelines, and all of them say the same thing. They've come from multiple countries, and we all say that if we could just educate the provider, we could solve this problem. 20 years we've been doing this, people. Just think about this. We have practitioners out there that we taught at the entry level of these guidelines, and yet they're still not implemented. And this implementation strategy that we've had has been to just educate the provider largely, and as you can see, it hasn't really dented this problem that we have. So the next question you might ask is, well, what are we spending all this money on? Is it doing any good? And what about the patient? Is the patient getting what they want? Well, why not just ask the patient, right? And when you ask the patient what they want, it's really pretty clear. They don't want wait and see. That's what they don't want. Isn't that funny? That's what the guidelines say that we should be telling them, that they should be patient. They're going to get over this. Well, that's the first thing they tell qualitative researchers, is that's not what they want. That's why they go see someone else when someone tries to tell them to wait and see. Okay? They want a clear diagnosis, and this is a problem for us because we know in most people with back trouble we can't give them a clear diagnosis. They want information and instructions. They want pain relief, and they want a physical exam. And this is, again, this notion of opportunity ought to be coming up in people's minds. We're one of the few professions that actually do this, that perform a physical exam on a patient, believe it or not. Even surgeons nowadays are spending less and less time on an exam. I can't tell you the number of patients that come to see me that I do an exam on, and they tell me, you're the first person that did an exam. And this is after they've come from a variety of people. And a surgeon now many surgeons now do a perfunctory exam, spend most of their time looking at the MRI while they're talking to the patient. That's essentially what's happening in the world out there. Opportunity, I think. Now, I think, and I think it's safe to say a lot of people agree with me, I'm going to make this profound statement. I think we fail with back pain. I think we can do a lot better than we do. And I think we fail no matter where we live. I just gave you all the data on, in the US, and I don't want to go through that again. But I want to talk about where we live in Western Pennsylvania, and then I'm going to ask you about what's going on here in Birmingham. All right, but I'll bet you're not much different than we are in Western Pennsylvania. In Western Pennsylvania, I have the opportunity to work with a large health system that has an integrated payer. So you've heard of these in the healthcare reform, they call it the integrated finance and delivery systems, when you combine a payer and provider. So we can now look at claims data, and we can look at also process data that's out there. So we formed this integrated delivery and finance system. I work at the health plan, and we have committees. I'm on the musculoskeletal subcommittee. And in 2009, we looked at some 2009 data in 2010, and these people were shocked. They spent $6.2 million on 937 cases of low back pain. And it turns out that it's the third largest cost bucket, as they refer to it, behind neoplasms and cardiopulmonary conditions in our commercial health plan. And the first question they say is, this can't be. We cannot live like this. Now, remember, we're in a fee-for-service system. So for us, it's nothing more than our system taking the money from their left-hand pocket and putting it in the right-hand pocket, right? But it was still concerning to them. And obviously, they're looking into the future where it's no longer going to be a fee-for-service operation. And really, regardless of how you look at this is unconscionable that we're spending this amount of money for this kind of a problem, especially when you look at where we're spending the money. Most of the money is being spent on unnecessary imaging, unnecessary procedures, and expensive, very expensive pharmacology. Most people I know are not getting better with these sorts of things, these sorts of interventions. Okay? And just so you realize I'm being fair here, a lot of money is being spent on repeated visits to rehab facilities. And in our system, chiropractors and physical therapists are thought of as the same. In fact, patients bounce back and forth between the two. And when we look at we look at charge codes, and in terms of what's going on with patients, lots of passive agents being used. And what do we know? What do the guidelines say that we shouldn't be doing with patients with back trouble? Doing a lot of passive treatments. So we're again, forget about this fact that I'm sort of throwing stones in my own house. Just take a step back from this and say, is there some opportunity here for this? And the answer to that question, obviously, I think there is. I think there's a lot of opportunity. I think we can come up with ways where we can reduce this unnecessary imaging, unnecessary pharmacology, and we can clean up our own act in our own house. When we get these patients into our system, start to do things that are more evidence-based with them. And in fact, you'll see now, you know now that some of the evidence coming out says that if the patients get to a physical therapist early, they're less likely to spend this money downstream. That's even without some assurance that they're getting the best care standards when they come to PT. That's just coming to PT. Imagine what would happen if we could put something in place where best care standards were adhered to. What a concept, right? I mean, I think we could make some hay here. I think there's tremendous opportunity here. We have to ask ourselves then, if we're going to get patients directed our way, which it looks like is happening now, how congruent is our practice with best care guidelines? And I'm going to put this question to you. How congruent is your practice with best care guidelines? Have you looked at guidelines? Do you read them? Do you know not just what you're doing, but what your practice is doing with these patients when they come to see you? Take a walk around in your clinic. Every time you see somebody with a backache that's got a hot pack on their back, you have to ask yourself, what's that doing to the value that I'm providing for this patient? And these are really what we have to be asking ourselves, and how I think we have to change a little bit. Now, if you followed our work, not all back pain is the same. We know this. We've done a lot of work to subclassify back pain. And if you go back to the guidelines, it really does not just bring out our work, but brings out a lot of people's work on back pain to show how we can subclassify people and match treatments that's evidence-based. And by being evidence-based, it means that when you're congruent with that approach, your outcome is going to be better with the patient. Okay, that's pretty clear-cut, pretty straightforward. So we know this, and I'm not here to go through the entire classification system or everybody's system. I'm here to tell you about just two components that I think are if we could attack these two components, then I believe we can have a huge impact on this problem that we have of spending all this money on people with back pain and satisfy the patient, okay, which is the big thing that we always need to remind ourselves that we need to do. So the two things I want to talk to you about are this lumbar spinal stenosis and the patients that we see that have elevated risk to transition to chronic. We're starting to see a lot of this. If you go back and your hair is as gray as my hair is, we first talked about these people using the Waddell non-organic signs and symptoms. Do you remember that? Some of you that are younger won't remember this. The older ones will remember this. And that transformed into fear avoidance, and it's now we've consolidated this whole process into something called a Keele Start Back tool, which is really a very good tool that we need to all start implementing. It's very, very successful in Europe, and it's now taken on a life of its own in the US. Again, trying to identify that patient who comes to see us with back trouble who has an elevated risk to transition to chronic, and if they transition to chronic, they're a person who's going to be a drug user, likely to be a heavy one of those opioid drug users. They're going to be exposed to a lot of unnecessary procedures, surgery, and so forth. These are the people we want to prevent that transition to chronic. So the first thing I want to talk to you about is a trial we did in Pittsburgh, and Right now, this trial is submitted and under review, but it's one of the it's one of the things I'm really anxious to see how this is going to be viewed. And you're one of the first people to see this, so you'll have to tell me what you think. This is you'll recall if you look at the title of this, Surgery versus Exercise with Patients with Lumbar Spinal Stenosis. This is really similar to what we all know as the SPORT trial that was published a few years ago. And in fact, we thought this was a good follow-up to the SPORT trial. Acquired lumbar spinal stenosis is a real problem. It's the most common diagnosis for people who are over 65 and undergo spine surgery. So how this translates, without going into the data, is remember that differential per patient differential? This is making up a lot of that differential. A lot of people getting surgery for lumbar spinal stenosis. Got it? 1994, 30,000 procedures at the rate of about $1 billion. The most scary thing here is the surgical rate has been increasing year by year by year. All right, and a lot of these people now are going on to fusions. So there's increased incidence and number of surgical procedures. Some people think it's because we're imaging more people and we're finding lumbar stenosis in more people, so it's that you find it, and and therefore the surgery is done with it. And this is a surgery not without complications. 10 to 15% rate of complications, and half of those complications are serious. So again, when you think about this from the standpoint of physical therapy versus surgery, we don't have to have a better outcome than surgery. If we had an equal outcome, we'd still win the game. Because I don't know that our complication rate is 10 to 15% and half of it's serious for somebody coming to see me as a physical therapist, right? Okay, so it was why we did it. The controversies have been and continue to be short-term outcome from surgery is generally good. Long-term outcomes become equivocal. And some studies report better outcomes with men than women. And the difficulty here is that it's very, very difficult to design a randomized trial in this, and we'll show you how we did it. But in the SPORT trial, they randomized people to surgery versus non-surgery, and half of the people that were randomized to surgery didn't get surgery, they crossed over to non-surgical. Half the people that were randomized to non-surgery crossed over to surgery. So the trial was impossible to analyze in the randomized format, so they analyzed it in the as-treated format. Well, they might as well have done a big cohort study. They lost the benefit of having the randomization in the first place. We wanted to avoid that in our study. Non-surgical treatments are not well recognized, not well published, and the outcomes with lumbar spinal stenosis we tend to use outcomes, the low back specific outcomes are generally not as responsive in lumbar stenosis as they are in some of the other low back problems. We'll show you how we tried to handle that. So what we did was we did a comparative effectiveness of a simple decompression surgery with a supervised exercise program that was conducted by physical therapy. We took people who were eligible, and I'll tell you how we did that in a minute. And here's the difference between us and the SPORT trial. They consented to surgery first, and then they consented to our study, and after that they got randomized to surgery or the exercise program. So you can see our attempt to do this in this fashion was so that we wouldn't have the crossover in the surgical group. We would at least have one arm of the study where there was no crossover, or little crossover. Got it? That's why we did it this way. And that's different. In the SPORT trial, this step was eliminated. They didn't consent people to surgery. They just went ahead and randomized them, which is why they had the crossover in both groups. So we did this as a randomized trial, and our primary aim was to compare these two approaches. And we looked at it 2 years after. Our primary outcome was at 2 years. So we admitted the usual suspects. They had to be 50 years or older. They had to be surgical candidates. And this shouldn't be surprising to you. All of the inclusion criteria you'd expect in this kind of a thing. And in terms of exclusion criteria, again, usual kinds of things. The one thing I wanted to point to here is that, two things I wanted to point to. First thing was that Some of our patients had previous surgery, but they couldn't have surgery at the level that was deemed appropriate, the level that was deemed the target. So we didn't do redos at those levels. Very few of our people had previous surgery, but we did let them in. And the second thing I wanted to show you is that we didn't admit to this study anybody who had a spondylolisthesis greater than 5 minutes. And those are people that really require a fusion, or at least the surgeons thought would require a fusion. So they weren't admitted to the study. Our primary outcome was the physical function part of the SF-36, although we did take Oswestry scores. We also did a lot of secondary measures, but I'm only going to cover the primary ones. So we admitted 169 subjects. We stratified by gender. We wanted to look at this female-male thing. So we stratified by gender, and we prospectively decided to hypothesize differences between men and women. We ended up with 74 randomized to surgery, 73 to supervised exercise. And the stenosis flow, the flow diagram looks this way, and I know this is kind of busy, but the part to get to is we found 481 eligible people. 312 refused to consent to the study. Remember, they consented to surgery first. And then we go in and tell them about the study, and they're like, forget it, my surgeon tells me I need surgery, I'm going to have surgery. They didn't want a 50% chance of being randomized to non-surgery. But we still found 169 who consented. Okay? And then we randomized those people. So when we look here, I want to point you down the surgical arm of the trial, because that's the easy one. Almost everybody got surgery. 4 people didn't have surgery out of the 87. So the design did its job. It got the people over into the surgical arm, and there was very little crossover into that arm. But look what happened on our physical therapy arm. Right away, before the 10-week endpoint, 23 crossed over, right? Then another 11 crossed over before the 6-month trial, but then only 3, and then only 2. If you add this up, more than half of the people still didn't have surgery at the 2-year mark. These are people that consented to surgery. I ought to be able to stop the talk right now, right? People that consent to surgery, over half of them felt they didn't need surgery, and really this was their call. They crossed over at they were told from the beginning, we're not going to withhold surgery from you. If you and your surgeon think that surgery is the best thing for you, at any point in the trial, you can cross over, okay? So that's what we did. And here's our outcome. And really what you see here are parallel lines. The intention to treat analysis, the surgical group did as well, the physical therapy group did as well as the surgical group. All right, and it was really a profound finding. We did an intention to treat analysis, and these are substantial increases in function. These are way beyond minimally important clinical differences in the physical function score of the SF-36, and the thing that's more familiar to people would be this Oswestry score. So you can see these discharge Oswestries are between 25 and 30, and they're coming in at around 40 to 45. Right? So these are substantial improvements. It's not as though that nobody got better. Everybody that got in the study, the group means are better. Now, when we looked at the as-treated analysis, we looked at the people that got surgery, the people that crossed over from PT to surgery, and the physical therapy group. And again, what you see are just parallel lines. There's no difference in the outcome. Okay. And finally, when we do our responder analysis and we look at proportions, we set our success at 0.5 as standard deviation. That's a big effect. But we felt as though somebody had to have a big effect for surgery to be worth it, right? And you can see that the same proportion of people reported success and failure with both arms of the study. So it was, the responder analysis basically mimics looking at the mean changes in scores. Now, the thing to keep in mind is that still a lot of people fail, no matter what you do with them, right? And then, of course, our what I think is even the biggest finding, and that's that women just don't do as well as men with surgery. That's the bottom line. Women don't do as well as men, and it's significant and it's clinically meaningful. And when our primary report is going to stop there, but when we did some secondary analyses of this, What was very clear is older women really shouldn't have surgery. That's what the bottom line is. The older, this is to me, if I wish I was 10 years younger because I could spend the lifetime looking at the reasons for this. I think it's a real finding, and obviously all findings need to be replicated, but I'm prepared to say this is a pretty real finding, and it's a fascinating finding because you can think about biological, anatomical reasons, you can think about psychosocial reasons. There's a lot of different aspects that we should be looking at on this. So over 50% of the people randomized to PT didn't have surgery after 2 years after consenting to surgery. Outcomes were equivalent in the intention to treat as well as the as treated analysis, and women don't fare as well as men. Those are our basic findings. So what do you think here, guys? Is there an opportunity here? Really? Okay, and how can we blow it? We can blow it by asking these, by standing there, stamping our feet, asking these people to be seen, and then giving them hot packs. Or not doing the right things with them. Now, this treatment that we did was not rocket science. Good entry-level PT could do this. A flexion-oriented treatment, a good exam of their lower extremities, finding out whether or not that person has OA of the hip, and that's why they have leg pain when they walk, and it has nothing to do with this lumbar stenosis they found in the back, and treating their hip. That's what we found, okay? Other issues that were picked up on were vascular problems, right? I'm not telling you guys, I'm not sitting here trying to tell you that somebody who has true neurogenic claudication can avoid back surgery by just coming to PT. What I'm sitting here trying to tell you is that some of these people that are getting operated on, the lumbar stenosis has nothing to do with their leg pain when they're walking, but they're getting operated on anyway, okay? So I think we have a phenomenal opportunity here, and I just told you that we can make a huge dent in these unnecessary costs. Now here's the other issue that was really interesting. I told you those 23 people that crossed over real early in the trial. You know why they crossed over, some of them? Because the copays were more expensive for them to come to physical therapy than to go get surgery. It was cheaper out of pocket to go get surgery. That's true, and that remains true today. All right? That is a problem for us. That problem that policy-wise we have to try to address. Okay? I think we have a phenomenal opportunity here. I really do, and I hope we don't blow it. I just hope we don't. I hope we really take advantage of this and move it forward. I want to switch gears and talk about these people that have a high likelihood of becoming chronic. I'm going to tell you guys something now that you may not want to hear. I think we spend too much time on people that are going to get better anyway. I really do. I mean, there are some patients with back trouble that we get them better a little quicker, but we probably overtreat them a little bit. And we don't spend nearly enough time on these patients that we think are kind of a pain in the butt to treat sometimes, okay? And I'm going to go through this with you in a minute. But you know, that's where we need to be spending our time. So this Keele Startback screening tool is a brief, validated tool. It was designed to screen at the primary care level patients that have prognostic indicators that are relevant to decision making. How that translates to you is, do you know these patients that are going to be responsible for all those costs that I talked to you about? These are the patients that are responsible primarily for the majority of those costs, unnecessary imaging and all of that. And can we provide an alternative with those patients? Can coming to see us provide that alternative? And I think the answer to that question is yes, and I'll show you why I think that, because it's been done. I'm just going to tell you. This is the Startback tool. Anyone who sits there and tries to tell me that 9 questions takes up too much time in my clinical day, I'm not going to give you the time of day. I'm not going to give you my time of day. This is a really simple test to give people. And it's going to give you profound answers. All right? And as a result of this test, you are going to be able to then talk about, put patients into these subcategories. You're going to be able to see the patient who's low risk, and really, for the most part, advice, reassurance, medication, maybe some manual therapy to speed it along, are the way you treat these people, right? And get them out of your clinic. Get them activated. They'll probably activate themselves. Okay? Maybe if they've got this problem where they get recurrences, try to prevent the next recurrence with them if you can. Then you've got these people that, based on the tool, you can say they're at medium risk, and really they have some physical obstacles to recovery, right? They need a little bit more concentration of your time and energy on looking at impairments, looking at other sorts of things, right? They need a little more intense intervention is the bottom line. And then you've got these high-risk people, and these are people that have psychological obstacles to recovery, and they really need a more enhanced group of. And what do you now? And here's the problem: when we look at our data, we spend the least amount of time with these high-risk people, and we spend the most amount of time with the low-risk people. And I think it's because we like treating the low-risk people better. They're more fun, right? Well, you know, you didn't get into this field only to treat the people you like. Okay? This is where the money is, guys. Right up here. The high-risk people is where the money is. If I had to advise a student, and I see some students out there, what they ought to do, you know, right now to have a real impact, it's not going to be to go get taught a manual therapy technique. That's not the issue. The idea is to go and learn how to talk to patients, reduce their fear, put their problem in perspective, and reactivate them in life, because that's what they need. Okay? Oh, unexpected. Unexpected. Thank you. So, just to tell you, I'm not up here just spouting. Okay? The StartBack tool has been very, very well researched. If you go to the Keele StartBack, just Google Keele, K-E-E-L-E, be sure you spell it right. StartBack, that's all you have to do. You'll come to their site, and everything's on the site. The tool is free to use, but you have to call it the Keele StartBack tool, otherwise they'll get mad at you. But otherwise it's free. The scoring's on there, and all of these studies are on there. And these are, I'm only picking out a couple of the studies. Very, very well researched study. This is done based on a trial where they looked at the tool, they looked at high, medium, and low risk, and they compared two groups. They compared the right treatments for that stratification versus just letting people go with usual care, right? And what they found was very, well, this goes through a little bit more of the intervention. The advice focused on appropriate levels of activity and return to work. This is what we're telling patients they ought to do. So when they say they had a little flare-up, your response is, well, sometimes you're tempted to say, well, let's rest today. No, that's not the response. The response is, let's work through this. Let's get moving. Pamphlets about exercise, get active videos. There's a whole bunch of tools that are out there to use. And in these high risk, we have to learn to better utilize some of the cognitive behavioral techniques that are out there. That doesn't mean we have to become cognitive behavioral therapists, but we have to learn how to use some of these tried and true techniques. Now, if some of you have ever worked in a chronic pain clinic, that's what they do every day. Everybody does this every day. All we're asking is that we use some of that in the acute situations for these particular patients, and it's profoundly effective. The stratified approach targets these medium and high-risk people, and when you look, you spend a little money early on. Guess where that money's spent? Well, if physical therapists are doing this, that's where the money's spent. But look what they say. The downstream cost savings far outweigh the initial costs of doing this. If that isn't reason for you to take a step back and ask yourself, wow, I can really have an impact here, right? I don't know what is. This has all happened in Europe, mostly, this StartBack revolution. Keele is a university that's in England, but we're starting to see it in this country now. In fact, I would tell you right now, it's not even innovation anymore. People are using this StartBack tool. It's spread like wildfire. It's now become in vogue. And look at this journal, folks, the Annals of Family Medicine, all right? And this is just another study where they did this, they call it an impact back, and they did this sort of sequential comparison of doing usual care, following people, looking at all the downstream costs, and then turning around and doing exactly what they did in Europe. Give the StartBack tool and then stratify care based on the StartBack tool, right? And what did they find? Well, the same thing. They did this risk stratification, as I just said. They did matched treatments, and they found the same thing. If you give these people this stratified approach, they're happier and they spend less money downstream. I think that's in the next slide. So anyway, it's starting to be done in this country. I don't know how much more you need to have before you have a threshold to act, but I would say it's about ready now. You ought to start thinking about this. Now, Tim Carey is a primary care physician, and look at this, Janet Freeberger, physical therapist, right? They're from the Shep Center in North Carolina, and they wrote an editorial in the Annals of Family Medicine, and this is part of what they took out of this paper. Should we try to adopt such an approach in the United States? Unqualified, yes. Are they teeing it up for us or what? They're saying physical therapists ought to do this. This is how we ought to be managing people with back trouble. If we don't answer the bell on this, we're crazy, people. This is an opportunity that is there and directly will affect this downstream cost. I don't imagine that our country is that much different than Europe. In fact, we're probably going to have even a more profound effect on costs downstream. So what do we have to do? Well, we've known this since 1997, what we have to do with these types of patients. Provide positive expectations. That means tell them, we're not sitting there trying to convince patients of what's untrue. We're trying to tell them that the natural progression is you can get better, right? Positive expectations. Schedule regular reviews of progress. Keep the individual as active as possible. Acknowledge difficulties, but avoid the assumption that activity should be avoided. This is what good chronic pain therapists do. This is what we need to start doing in our acute centers. Communicate that increased time off for work diminishes the likelihood of returning. I learned this from Dr. Earhart when I first started practicing in Pittsburgh. When these people come in on workers' compensation and they think they're going to make a killing because they hurt their back at work, reminding them that the longer they're off work, the less likely it is that that job is going to be there for them. And what are they going to do without that job? And then you also remind them they can't sue their employer. That's a right that was given up with workers' compensation. That's all news to some people. That's sometimes all you really need to do. Don't offer this elaborate speculative explanations. This is going to be hard for some therapists. Oh, I think your pelvis is out. I think all of these things that we really are unsure about, we probably want to stay away from with patients like this because they latch on to it. Guys, I'm not trying to tell you don't tell a patient there's something wrong when you really think there's something wrong. But with the vast majority of these patients, they don't have a bona fide diagnosis that you can really say is causative to their back problem. So don't play into it. Just like surgeons, or just like their PCP shouldn't be telling them they have degenerative disc disease. Do you guys know that degenerative disc disease is like telling somebody they have gray hair? Because as your hair gets grayer and grayer, your discs start degenerating more and more and more. I have degenerative disc disease. I probably have stenosis. I just turned 60 last month. I probably have lumbar stenosis, right? And if I went into a surgeon and told them that my back hurts and it really gets bad when I walk, he'd flip up an MRI and I guarantee you would offer me surgery. Guarantee you would offer me surgery. I don't know is fine, guys. I like to tell patients, I don't know what to do, and we don't know what to do when you have a headache, but I know if you take an aspirin, it gets better, right? Encourage patients to recognize that pain can be controlled and activity can be maintained. And after a while, they start believing it themselves. Psychologically informed PT, this is not rocket science, is all I'm trying to say. And you don't have to be a psychologist, so, it's not that hard to do. But you have to want to do it, and you have to do it. So I'm finished with this evidence-based. I've given you my spiel with all the evidence that's out there in these two areas, which I think will have a big impact if we could do it. So how come we don't implement? What are these barriers to implementation? Okay, I'm going to go through those really fast with you. I'm going to tell you what the barriers are, but I'm also going to offer what I think are good solutions to these barriers. So first is, what's your threshold to act? If A and B, then you have to do C, and you see that from the literature. Are you going to do it? And more importantly, are you going to do it as a system? Because most of you aren't out there as one-horse shops, right? You want to make sure that everybody's doing it out there. Uh-oh. Barrier number 1. Look what we get paid to do. See, all these things I have in yellow are all things we can check off. They're all this is a Medicare fee schedule, guys. These are things you can check off and get paid. These are all things that are useless. Sorry, not going to help you. So I hear all the time from our practice people that, you know, if we stop doing all of those things that we know are not really effective, we would really have a severe hit to our bottom line. I can't afford that where I work. I get a revenue stream from that bottom line. You know, that bottom line pays about, 40% of my salary. I can't afford for them to lose money. This is a barrier. It's a bona fide barrier. All right? I don't want to make it. And here's barrier number 2. From 2000 to 2010, when we monitor these things, what happened to reimbursement rates? Cut, 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 cut. So what happened to rehab managers? We got to increase our bottom lines. How did they do it? Well, there's people that came out and looked at your billing and showed you how you could charge more so you could bring that bottom line up, how you were undercharging your patients. There are a certain number of procedures that you didn't charge, right? Now, this should not be a source of embarrassment to people or a source of shame. This is what people did to make ends meet, to make their bottom line. Reimbursement got cut, you had to figure out how to charge more. This was a strategy. These people came out and showed you how to do it. Okay? All of a sudden you pull this away and it's going to hurt your bottom line. So when we talk about best practice and we talk about taking evidence and expertise and patient values and preferences and having that guide our treatment with patient, we can't ignore money. The solution to this is going to be when we begin to bundle. And we've already seen this where we are now. We have now a service-specific bundle to physical therapy for people with low back pain because we went to our payer and said, quit making us do this. If you want us to start adhering to best care principles, then pay us a different way. So I don't have to have our therapists who are all, they're very interested in bottom lines because, let's face it, guys, we're not in the business for charity. We're in there to, that this is what we do. So we have to, we can't do this. We start to see the government now doing this. Financial alignment initiatives and for Medicare and Medicaid enrollees. These are opportunities for us to make our case. Get rid of this fee schedule and let us do what is really important for the patient and have us, and not have it hurt us when we start doing the right things. Some people say it's show me the money. And I put this slide up purposely because this is one of the issues with academia versus the clinical side. If academia doesn't begin to understand that the clinical side is under this pressure, they'll never understand why this implementation has become a problem. They'll misread it as something that the clinic doesn't want to do. All right? The clinics are trying to survive. That's the bottom line. Here's barrier number 3. You don't improve what you don't measure. We learned this a long time ago. You know who taught us this? The Toyota Manufacturing Company taught us this. I use a slide, and I didn't do it for this, but I show a slide of a car that was imported in the 50s. And I ask people if they know what kind of car it is, and they look and they say, it's a Studebaker, it's this, it's that. And then I say, nope, it was the most unreliable car ever introduced in this country. And they're looking at it, and they still can't get it. And then when I tell them it's a Toyota, they step back and they think. And it was. Toyota put in the first cars they ever imported to this country were terrible from a reliability standpoint. Now, what did they do to get better? Obviously, they moved. They did something right? Oh, I know what they did. They solicited a bunch of randomized trials. And then they got the results of these trials for every little part of their their assembly line. And then they just gave it to the assembly line workers, and the assembly line workers just went along and made everything right. That isn't what they did. They put a total quality improvement process in place, right? Where everybody was accountable to their job. And we just haven't gotten there yet in healthcare. And this is what we really have to start doing. You don't improve what you don't measure. We overestimate this passive diffusion. We definitely overestimate it. We think, and over the years we've thought, all we have to do is put the evidence there, and it'll magically be implemented and taken up. And it's not happening. And then here's I don't know who came up with this saying, I don't know where this came from, but it's the most annoying thing I've ever heard. It takes 16 years for a practice, for something to get into practice. That is a crock. I don't know where that data came from, but you change the financial alignment and that will be implemented tomorrow. I guarantee it, it'll be implemented tomorrow. Because so this passive diffusion, this is my slide for passive diffusion. In our own clinic, attached to the mecca of classification, where most of the work on classification came out of, we have trouble getting our clinicians to implement best care standards. We're no better than you guys at doing it, okay? So obviously, if passive diffusion was going to work, we would think it would work in Pittsburgh, but it doesn't. Okay? We like to blame. Anybody know who this guy is? You want to take a guess? That's Madoff. That's right. That's right. Okay. Everything that was positive, it was because of what I did. Everything that was negative, it was not because of what I did. Okay? We do this all the time with our students. We make our students stand up in front in their capstone projects, and they have to present data on the patients they saw in their one-year internship. And we don't care about their successes. We truly don't. We want to know about their failures and what they're going to do about it, right? And they try to get away with, well, you know, here's all the people I did a success with, and here's our failures, and most of those patients were non-compliant. Time out. They don't get away with that. You know, you have to, for the most part, take ownership of what's not a success and figure out how to change that. But how do you know it if you don't measure it? But the first thing you have to do is not blame. That's a key. So we're averse to this routinely measuring clinical process of care. But we're not any different than everyone else is. We tend to be averse to it. But like Alan Jetty said in the Macmillan lecture this year, we have to put out now people that embrace measurement. Okay? I was talking to your colleagues here last night at dinner, and we had an interesting conversation about, you know, should we be thinking differently about prerequisites to get into PT school? If we want people who embrace measurement and embrace data, what does physics and chemistry have to do with that? Just something to think about. So how do you bridge this gap? Okay, the first thing we have to recognize, ask the question, how do you change your behavior? I will tell you your first step is you have to measure your behavior, because you can't improve what you don't measure. You know, and this is Toyota. This comes right from the Toyota manufacturing. You can only manage what you measure. Okay, only then can you have a critical analysis of your current behavior, and there you develop a plan to improve. Is it knowledge and skill? Do you have to go out and get different knowledge and skill? Are there environmental factors that are there, right? Do you have to become a little more patient-centered in what we're doing? And this list will go on and on and on, okay? And don't allow blame. There's something that's accountable to you, something you can do on this. Certainly there's going to be non-compliant patients, but that's not the whole story. So how do we evaluate performance? Okay, that's really gets down to it. How do I evaluate whether or not, well, you first have to reorient clinical performance to how am I complying with best care standards? Because that's the performance I'm talking about, right? How do I comply with best care standards? Well, barrier number 7, we rely on imprecise and piecemeal measurement techniques. And we use these performance instruments with our students, the APTA CPI, right? And we have one in Pittsburgh because we didn't like the APTA CPI, so we developed our own, right? You never see these instruments used on practicing clinicians. How come? Could it be that they're really not reflective of what we really want out of practicing clinicians? It could be one of the answers. It could be that there might be other explanations to it. For whatever reason, they're not used. I don't think these instruments, however, capture what I'm talking about. That's the adherence to best care standards comprehensively with any one person that's out there. And then we do this other thing, chart audits. And this is why my faculty doesn't like me to lecture to our students, because I make statements like, I believe it's the greatest waste of time in clinical environments. That's exactly what I think. They're, for the most part, how well do I chart versus how well do I manage patients? And they're hit and miss. They don't give you any sort of comprehensive assessment of what's going on with patients. And I'll go back to if my goal in measurement is to see how I'm adhering to best care standards, okay, and tracking outcomes of patients, which I think is what we're talking about, a chart audit's not going to cut it, guys. It's just not going to do it. So we need to develop different things. Oh, I know. The electronic medical record. That's going to be our answer, right? How many of you now interact with electronic medical records? Okay, good, good. How many of you are unbelievably frustrated with Epic and the electronic medical record? Okay, great. I'm happy to see that. You ever hear the tale, The Emperor's New Clothes? All right, for those of you, I'm afraid I've prepared this not just for people with gray hair, but also for people who are younger than I am, all right? So I'm going to tell you about The Emperor's New Clothes. That's a short tale by Hans Christian Andersen. It's about two weavers who go to the emperor and promise a new set of clothes that are going to be invisible because it's unfit for their positions, for the position of the people looking at it, because they're either stupid or incompetent. So the emperor parades around in his birthday suit, and everyone is saying, oh, it's wonderful, it's beautiful, oh yes, and everything else, until he comes along to this little child who says, but he isn't wearing anything. And of course, that's the tale, you know. And it's been translated over and over again. It's sort of my saying with electronic medical records. The promise of the EMR. We are having a huge amount of frustration with our EMR, trying to implement measurement tools that we can measure best care standards with and outcomes. Now, they tell us that it's going to get there, but it's not been easy. Recall that they were passed as part of the stimulus package. It was supposed to cut down on paperwork, medical errors. Medical pilots were going to open up more new and efficient ways of doing things. They've been unbelievably expensive. At the partners up in New England, over $800 million to implement Epic. Okay, I know our facility, some brilliant mind in our facility decided to put Cerner in the inpatient service and Epic in the outpatient service. Now there's a good idea, right? There's a real good idea, right? You can't even get these things to talk to individually to one another. You're going to get one to talk to a different system, right? And really the question is, are we any closer to measuring practice? And this is where is the emperor naked? I bring this up, I say this a lot of times at meetings. I get the Epic people very upset at me, okay? But I think I'm told repeatedly that we're going to get there. But I share the frustration that people have, because right now this is the rate limiting factor for me in the research I want to do. Because for me to do the research I want to do, I have to measure this in parallel with our electronic medical record. That's what I have to do. I have to measure clinical behavior in parallel. And that means my clinicians have to double book things. And they don't like doing that, right? But this is what we have to do. But guys, you don't improve what you don't measure. That's the bottom line. And you can't ask people how you're doing. How many of you know about Weight Watchers? What's the first thing you do when you get to Weight Watchers? Well, how come they just don't ask you how much you weigh? That's a lot like asking a therapist how their patients do. It's exactly like it, okay? You have to measure this. You know, you have to measure adherence to best care standards, and you have to measure outcome of your patients. And you have to look at it. I've been doing this since the mid-1980s. I've been tracking this in real time with real clinicians, okay? And I can't tell you the number of times. First thing that happens is you wouldn't believe how surprised they are. They overestimate how good they are. Everybody overestimates how good they are. I went up to Dr. Earhart, perhaps the best practitioner I ever knew, okay, in my life, and showed him his performance. And he was astounded that his patients were leaving with Oswestry scores still above 20. In his mind, they were well below 10. Okay? Now, there's nobody who's going to get better outcomes than he is, but this is just the way it is, guys. I kind of think about the baseball player who's successful 3 out of 10 times. And I'm wondering if that's going to be a good average for a lot of people, you know, that are really in the trenches working clinically. The bottom line is you don't improve. Whatever it is where you are, wherever you are now, and whatever your average is, and whatever you think makes up your average, it's the baseline that you're going to use to improve upon down the road. But you're never going to start improving until you measure it. You can measure it. This is sort of the design we use right now. The first thing you have to do is figure out what it is you're going to measure. This is the design of a clinical database. And hopefully you use evidence-based practice principles as you're designing this. I know this is hard to read, and I don't expect you to read it. I'm only trying to get it across conceptually. But I'd be happy to give this slide to anybody who wants it, because this is not proprietary. This is not rocket science, as I said. You design these clinical databases, and right now we get groups of people together who have expertise in the areas, and we put them together with researchers who know the literature, and we put administrators in place, and we put a lot of people, and I don't care what anybody says, the job is to get it done, and get it done succinctly so it can be done in the clinic on an everyday basis. Once everybody agrees upon what to do, then you just collect it over a period of time. Collect this information over a period of time. And then you evaluate it for compliance. Did you get a data set for every patient that was possible to get one for? Right? That's a problem for us. That was a problem at first. Now it's not a problem because it's routine. The therapists do it. We test according to these algorithms that are a lot of times in guidelines, but even if they're not in guidelines, you make decisions on your own. If A, B, and C, what are we going to do with that patient? You know, and so forth. You make those decisions on your own, and you simply ask the question, when we got those people, how often did we do what we said we were going to do? Right? And when we didn't do it, why? Because, you know, there's a good reason sometimes why not to follow the evidence. Sometimes that's not what the patient wants, right? Anyway. And then there should be some level of outcome assessed. If you do this, and you do this in a comprehensive manner, you can then take this information, and where the real power of this information lies is when you combine that with other data. How do you think we know in our system that people who adhered to best care standards saved money for our insurance, our integrated payer down the road? We knew because we then took those patients after they finished with us and looked at their claims data 1 year after. And we knew who adhered to best care principles and which patients weren't adhered to best care principles, right? That's where the power of something like this lies. So, you know, in our situation, design the database with the people that are going to be in the trenches using it, come up with something that's usable. My first crack at this, I told our people that were looking at this, our back experts, no more than 1 page. You know why? I knew it wouldn't get done if it was more than a page. Because remember, they're doing this in addition to all the other charting they have to do. It's a parallel process, I see. So it can be done. That's my point. And we don't have, there's no more good excuses for this, guys. I don't want to do it this way, then go work somewhere else. I mean, this is sort of a top-down approach that has to get done because there's no more time for this, okay? My present way works in my hands. If you collect the information and the data and it does work in their hands, great. Then tell me what you're doing so we can emulate you. But don't sit there and tell me it works in your hands without showing me it works in your hands, okay? And I love this one. You're taking away the art of physical therapy. I don't know what you guys think about art, but I sort of think about you take this piece of granite and you make this out of it, okay? And let me ask you something. What do you think Bernini did when he did this? I think he went to work one day and said, gee, I think I'll take a little off here. Oh, I think I'll take a little off here. Art is a systematic process, people. You don't produce these works of art without going through some systematic process, right? And it's people went to this particular sculptor and learned his process. And it took them a long time to learn because it took a long time to learn the systematic approach to doing this. And this approach was replicated by his predecessors, his people that followed him, okay? My point is, don't discount art. If you want to call yourself an artist, I don't have any problem with that. But don't think art is the same thing as doing whatever you feel like doing. in the clinic. Your patients are expecting a little more than that. All right, so coming to the end. This is how I knew Marilyn. This is a study that was published in Physical Therapy that was based on her doctoral work when she came to St. Louis. That's when I met her. I met her in 1980, 81, 80, somewhere around in there. I don't know exact date. Whenever she came to St. Louis, that's when I met her the day she came there and made an agreement with Steve Rose that she was going to do her doctoral dissertation work in our labs at Washington University. At the time, it was a magical time at Washington University at that period of time. She came in perfect, right at the perfect time. And I got to not only practice with Marilyn, her and I were, Steve Rose had this unbelievable notion that we needed to have more practice opportunities as a faculty. It wasn't enough that we were involved in the Irene Johnson Institute for Rehabilitation, which was Washington University's practice. He was always looking for new and different things. One day he came to Marilyn and I, and he said, I signed a contract with a substance abuse rehab place to provide physical therapy. And I looked and I thought, I knew what was coming because I was the practitioner, And he looked at me and then he looked at Marilyn and he goes, I think you guys ought to go cover that contract. Marilyn didn't have a license. I don't think she thought she was going to have to practice in Missouri, right? So here's my story. I was Marilyn's clinical instructor. She was the student who practiced in this clinic with me. So I practiced with Marilyn, and I've got great stories about this practice. It was first of all, it was a very worthwhile thing to do. There were physical therapy needs in this clinic, even though at first I couldn't fathom what they might be. But when you have substance abuse, you can imagine there's trauma, and when there's trauma, there's injury. And there were things for us to do there. So and we did them. We had a ball doing it too. And then the best part of that experience was it was a 45-minute drive to get there and back, and we drove together, going out and back all those times. Marilyn was an icon already in the field. I was his peon. I had just gotten my entry-level degree in 1979. Here it is, 1981. And I spent most of my time practicing and trying to learn the ropes of research. And I remember her coming up to me one time and saying that she wanted me to work with her on a research project. And I just couldn't understand that. I mean, I thought to myself, my God, she wants me to work on a project with her. And her and I, it was a clinical correlate to her study where she was looking at these length-associated changes in muscle in these rabbits, and she wanted to do the same thing in humans. So we were taking tape measures and measuring lengths of hamstring muscles on humans, and then doing measures of strength on these changes. It was a ball. We just had a great time. And Marilyn was up in St. Louis. She had a lot of time on her hands when she wasn't working. So we spent many a night at some of her favorite watering holes in St. Louis, and we had a great time. Just a wonderful time. This picture was taken at my wedding. Marilyn, Jules, and Steve drove all the way to Buffalo for my wedding, and we just had a great time. It was just like old home week, having them there. My brother still talks about Marilyn. He met her at the wedding, and they got along very well because they drank a lot of beer together, and they danced a lot. And my brother jokingly said to me one time, he asked about her a lot over time, and he said, where's that woman from Alabama now? And I said, well, she moved back down to Birmingham. And he said, did Anheuser-Busch run out of beer? And I said, I laughed, and it was Marilyn's sort of approach to, and I think we all know that, she just had that influence on people. that profound influence that everybody keeps remembering. And that influence was whether you were at work or out of work with her. It was just a great thing. Finally, I have to tell you, when I took the chair's job at the University of Pittsburgh in 1994, Marilyn was one of the only people that said to me, "Good, it's where you belong." Everybody else was saying, "You're crazy. It's too early in your career, your research is going to falter, blah, 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 blah." Marilyn, it didn't take her but a New York minute to say, "Good, that's where you belong." And I don't know, to me that helped. It helped an awful lot because I was sort of indecisive about it. And when you had this trio, think about this, these personalities, right? Most of you don't know Steve Rose. Steve was like a dog on a bone when he had things to do and wanted to, he knew nothing but work and worked diligently and very, very focused. And as one of his mentees, you followed Steve. You just ran as fast as you could trying to follow him and never seemed to be able to catch up with him. You know, you were always just doing that. And it was a great way to learn because he would, you know, when he did stop and kind of pull you up, profound learning with him. Jules was like the Doberman. You know, he was the mentor by terror sometimes, it seemed. You know, wonderful mentor, but had no qualms about asking me if I showed him a first draft of a paper, wanting to know if the plane was pressurized when I wrote the paper on the plane. These are the kind of things. This was the kind of. So you can understand, these were my two mentors when I first got to St. Louis, and all of a sudden Marilyn comes along, and you know, she could do all of those things, but not as harshly. Marilyn could just look at you and put you in line. You know, those steel blue eyes that she had that just stared at you and put you in line. And always just phenomenally helpful. That's what she was to me. I missed her when she left St. Louis. I missed her tremendously. We kept in touch. Our phone bills were very high because, like I said, over the time getting my own Ph.D., there's a lot of things you can lament, and Marilyn was always the call to lament to. And she was always the one that listened to you for a little while, and then you knew it was time to just get back to work. And then, of course, when I moved to Pittsburgh, it was the same sort of story. So it was she was just a wonderful person in my life. I can't tell you again how honored I am to do this talk. These three kind of sit over my shoulder a lot with everything I do, and not just what I do professionally, but what I've done personally. And this is the picture that I see all the time. So I think I'm able to answer questions now. If anybody has questions. How do you answer? How do you ask a question after that, right? Anything? Well, again, thank you very much, guys, for listening.